our weekly radio broadcast, The Heart of Innovation, to get underway with my co-host, Dr. John Phillips, and we're going to be joined
Hello,
today
everyone.
by Dr. Barry Tedder as well. So give us just a few moments and we will get this show underway. We have our producer, Colin. Colin, say hello so everyone knows your voice.
Hi, everybody. How y'all doing?
Fantastic. So he's in studio and he is going to be helping us with some of the commercial breaks and making sure that we stay on time and in line.
Sorry to interrupt. 5 seconds till there.
Perfect timing.
Turn your voice up, Colin.
This is 8:60 a.m. The Answer.
Sponsored by The Way to My Heart Incorporated.
Welcome to the Heart of Innovation. 60 minutes that could save life and limb with new breakthrough ideas and innovation changing the healthcare landscape. Brought to you by patient advocacy group, thewaytomyheart.org, in partnership with Cardiovascular System Incorporated's patient advocacy campaign, Take a Stand Against Amputation. Here are your hosts for the Heart of Innovation, Emmy Award-winning journalist and founder of The Way to My Heart, Kym McNicholas, and interventional cardiologist and founder of the Save My Piggies Health Education Series, Dr. John Phillips.
Hi, everyone, and welcome to the show. When peripheral artery disease reaches advanced stages where patients' arteries in their legs are completely blocked and they can barely take a step without excruciating pain, they're awakened from a dead sleep with leg cramps they liken to the worst Charlie horse you can even imagine, with some even nursing a wound that won't heal on their foot or their toe that's infected, and some even having developed gangrene. Time is really of the essence. Time is tissue. So when a doctor says, hey, patient, you need your arteries opened up, and I'm ready to do that for you, they have this glimmer of hope for some much needed relief for their unconscionable pain. But when insurance companies delay approval for these limb salvage procedures or even reject them for whatever reason, and we're seeing this more and more often these days, it's really the patient who's left to suffer from pain, in which I hear not even a narcotic, not one narcotic can even cut through. But the patients, they're not human beings to these insurance companies. They're purely an entry on a spreadsheet. They're a cost to cut. Insurance companies look for any reason to deny claims, whether it's a media article filled with flawed data that Aetna and United Healthcare are now using to make it more difficult for these advanced stage peripheral artery disease patients, known as CLI or critical limb ischemia patients, to have limb salvage procedures, or even in Michigan, where one insurance provider denies limb salvage on patients who don't see a certified vascular surgeon, as if a trained interventional cardiologist or a trained interventional radiologist in limb salvage aren't good enough to open up these arteries or aren't qualified. And don't even get me started on Cigna using an algorithm to review and often reject hundreds of thousands of patient health insurance claims, with doctors as medical reviewers simply rubber stamping those denials without reviewing each case. At least here in California, there's a state law that requires that insurers conduct a, quote, thorough, fair, and objective, unquote, investigation into each patient claim. So thankfully, just in the past couple of weeks, we're hearing that there's a class action lawsuit that's been filed against Cigna. So we'll see what happens there. But I'm really curious from a doctor's perspective, what it's like for them when it comes to being second guessed by insurance providers who aren't in direct contact with the patient. That's what we're going to talk about during this show. We have with us Dr. Barry Tedder from Jonesboro, Arkansas. He's going to be joining us. But I think, Dr. John Phillips, it's about time I bring you in, my amazing co-host.
Oh, Kym,
my soapbox.
yeah, like you pulled the pin on that grenade. Gloves are off. I love it. What I'll do is I'm gonna maybe play devil's advocate a little bit. So good cop, bad cop. But yeah, no, I hear what you're saying. It's very frustrating. And I understand what insurance companies have to do. Clearly, I understand what I have to do and my colleagues have to do for the patients. You try to make a win-win out of it for everybody, but it is becoming more and more difficult to kind of get some things done for patients. But it's going to be a conversation. I'm really looking forward to hearing Dr. Tedder's thoughts, and I think he has a patient kind of problem that he's going to share with us along the lines of not being able to have a procedure approved in a timely fashion. So it should be an interesting show. Definitely going to be provocative for sure.
It will. So let's kick it off with a moment of inspiration, a little positivity here.
Dr.
Yes.
John Phillips, spectacular vascular moment of inspiration.
All right. So today I was trying to figure out, okay, who can I quote? And I was looking at events in September 30th, to this day in history. So did you know that in 1846, the anesthetic ether was used for the first time by an American dentist to extract a tooth? Interesting,
Oh, wow.
right?
Yeah.
And also in 1938, they signed what was called the Treaty of Munich, which was signed by Hitler and Mussolini and Chamberlain, the prime minister of Great Britain, that forced Czechoslovakia to give some territory to Germany. They thought signing this would prevent war, but that kind of backfired. But anyway, speaking of backfiring, James Dean was killed today. His Porsche, I think he was in California. He was driving to go racing, and he was killed by another motorcycle, or not by another motorist. But anyway, he's quoted as saying, among other things, and he's only 24 when he died. But I thought this was kind of interesting. And we as interventionalists are always discovering new things, or trying to discover new things, like any physician. But he's quoted as saying, "I think the prime reason for existence, for living in this world, is discovery." So let's discover. let's have a show about discovering what it takes to get some procedures approved in the United States with our current climate of insurance pushback.
I also love that you picked that quote, because medicine is a practice. We call it practicing medicine, and there are new discoveries every single day. And that's what's so interesting when it comes to insurance, that when I was talking to an insurance expert just the other day with Fulcrum Strategies, he was saying that not one insurance company wants to be the first to actually cover a brand new procedure. He was referencing even that not one insurance company wants to cover a lot of these new weight loss drugs, because then you have the situation where, maybe in a year, another study comes out that says, whoops, they don't work. You kind of wasted your money. Now you have bigger problems with these patients. But also you have another interesting problem where when the word gets out that they're the first to cover a certain procedure or a certain medication, the patients all run to them and all want to be covered by that particular insurance company. And that costs that insurance company money.
It is pretty interesting. But I think, I don't know, insurance executives, we've all dealt with insurance folks for prior authorization and things. You want to assume that their kind of heart and their objective, their lens is focused on the patient, and sometimes it isn't. And that's where I think we as physicians kind of band together and, really have to be, advocates for our patients. And I know we only have 30 seconds before the break, but I can tell you that if I've never run into an insurance company that will not cover a procedure after I have jumped through the hoops that maybe I didn't want to jump through, but you basically have to, make your claim and they have to approve it, but they do it usually, but it just delays care, which is frustrating.
Well, coming up next on the Heart of Innovation, we are going to get into the heart of this discussion and bring in our special guest, Dr. Barry Tedder, interventional cardiologist from Jonesboro, Arkansas. He has a story to share.
Leg health can indicate risk for heart attacks.
Everyone's clear on that side. Just saw your message.
Yeah, sorry about that. I should have done it sooner.
Or P.A.D. P.A.D. is plaque.
Done what?
You're all good.
The leg artery.
Colin likes to sometimes take us out.
Oh,
so-
yeah, Colin. All
And,
right.
and so, I like to give him that, opportunity because it's kind of fun and it also adds to our, production of the show. And he has such
Can he
an
bring us
awesome,
back in?
sexy voice.
Can he bring us back in?
I mean, if he wants to do that live versus playing the
Oh,
thing, that's fine with me.
I'm not gonna lie to y'all. I appreciate it.
but
I gotta get over my willies. So let me. I might try it in not this session, the next session, but let me get ready. Also, we
All
have
right.
about 1 more minute till we air.
all right, you guide us.
Okay, are you, so we can, do you have another quick bit to say? I think you should take us back. And I just like the doctor to doctor interaction on this
Yep.
because you guys have two sides to this, but I'd love to, because Dr. Tedder literally just had the call and this situation, resolve itself just a couple days ago.
Okay, yeah, let's do it. Let's do it.
So it's really timely.
So Barry, we'll just
Let everyone know. 30 seconds till we air.
I'll just introduce you and let you tell our story as my dog's barking.
We love barking dogs. I'm all about it.
It's a Bashan, 4 pounds soaking wet, and I don't
10
know.
seconds.
Love your bathroom with free upgrades. Call
Darling, quiet.
800-981-8177. That's 800-981-8177.
This is 860 AM. The Answer.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. Thanks for joining us. Happy Saturday. Kym and I are live on the air, and we're going to welcome Dr. Barry Tedder, interventional cardiologist. And Barry, we're kind of on the topic of insurance companies and maybe delaying approval for procedures, but this really hit home for you and a patient not too long ago. Do you want to share the story?
Yeah, sure. Thanks for having me on the show. We're kind of used to the insurance process approval. It's frustrating. It takes an average of 14 days to get somebody approved for a peripheral artery coronary procedure. And you have to jump through all the hoops. We have to make sure the history is correct. You have justification. Of course, there's two categories. There's the claudication patient that is relatively stable, that you can afford to wait. And then there's the critical limb ischemia with foot ulcers or gangrene or rest pain that you really need to move on with, but they treat them the same. It's 14 days, and then you might get denied, and then it's another 14 days. So we've got multiple people in our office working on that. We have a kind of two or three people, and one of them is a clinician, a nurse, that has to make sure all the clinical stuff is appropriate. So we go through all that, and that sort of stays out of my hands for a little bit, other than making sure my note is documented right. And that takes a little bit of work to make sure that's what the insurance company wants.
So Barry, if I could just interject real quick, can you explain to our listeners how this process works? So, I'm your patient, we talk about a procedure and you say, okay, I'm going to schedule that. And so the patient oftentimes assuming that it's going to get scheduled the same day, or we're going to schedule it that day and they're going to get it done like the next day or in a few days, but that's not the case, right?
Right, correct. Yeah. We have to tell them we'll contact them because we don't know when it's going to be approved. And so, kind of to jump into the story of this lady, she's 50 years old. I first met her when she was not long ago, having heart attacks. So we've done coronary stents on her, and then she kept re-occluding her stent. So we went through the process of that. So she's not exactly a healthy patient. She's a diabetic smoker. And so I noticed, we were talking about that she has severe claudication or leg pain when she walks very short distances in both legs. And I evaluated her and did a CT, and she has long chronic total occlusions of both superficial femoral arteries.
Oh, wow.
So those are sometimes difficult to do.
Mm-hmm.
And this insurance company called Summit Community Care, which is a branch of Anthem, said in their approval process that any lesion length longer than 5 centimeters would not be approved. And I'm like, what guidelines did that come from? I mean, I don't know what you think about that, but we're doing chronic total occlusions all the time, and most of them are fairly long.
Yeah, so
Well,
I think just
especially when they
for
don't want you to treat earlier, especially when, a lot of people are asymptomatic to the point where, this short focal lesion becomes this long calcified occlusion, right? Where their patient's ability to grow collateral vessels, to reroute blood flow, disease has far advanced the body's ability to do so. And there are a few options.
Yeah, and just for our listeners, so the superficial femoral artery is basically from the groin to kind of the above the knee. It's upwards of 30 centimeters. I would say anecdotally, maybe 20% of cases I treat, less than that, have blockages less than 5 centimeters. So that is the most ludicrous thing I've ever heard. Oh boy.
Yeah, they sent me some guideline articles to their guideline, and some surgical guideline articles that kind of said, those are not the best outcomes. Well, yeah, right. They aren't the best outcomes. They're very difficult. And it almost looked like they wanted me to send them for femoral popliteal bypass, because it's, in the old days, that was considered, for long lesions, the best way to do it. And nowadays it's considered equivalent.
Yeah, I mean, it's reasonable option, but for me, I usually take a crack at it with balloons or stents before I send the patient off.
Yeah, at least try it.
I even looked up some guidelines, and they're like endovascular first. That's what they said in the guidelines, was endovascular first, because the outcomes generally are equivalent. And there's so much morbidity, there's so much problem with operative complications with femoral bypass, particularly in a ill patient that's already had multiple heart attacks, reduced heart function. You're not going to send that person to femoral bypass. No. And on top of that, your surgeon probably won't bypass them anyway, because they're still smoking, which is another issue we have. Surgeons don't want to do fem pops bypasses if they're still smoking a lot. So anyway, I went through the process. Okay, fine. She's stable. We can wait. So first denial, I think that went through a cardiologist. And
now, did you try her on well, was her ejection fraction
like 40%?
So kind of borderline.
So actually, to backtrack, for some reason, I got approved to try the first time, and I had a failed intervention. I got dissected, and that's not terribly uncommon. And you just kind of regroup and try another time, let all the dissections heal up, and bring them back a month later. I was going to come back, pop a teal stick, and try to get it open. And that's when this whole process got awry. So when I was trying to get approval, I decided, well, I'm going to do the other leg first, then come back, let that heal. And so I got denied. So we wait those 2 weeks or however long. Then I got a second denial. And by now we've gone from about June to, I don't know, early September. And she's sitting there, can't walk 10 feet without bilateral leg pain. Yeah, I did try Platel. She couldn't tolerate it. She stopped taking it. And, you always got to have a walking program, have failed a walking program. That's part of the insurance indication, and which is reasonable. You should try to walk claudicants and see if that improves them well enough they don't need a procedure. But, when people can't walk 10 feet, they're not going to improve with a walking program because their pain is so bad. So second denial comes from a pediatrician, I think. And then I'm like, what?
Now, were you able, Barry, to have a peer-to-peer with them and kind of plead your case?
Yeah, for some reason there was no peer-to-peer. And I'm saying usually there is.
Yeah.
So then I told my nurses, I said, no, we cannot stop here. We got to do the next level. I didn't even know what the next level was. I thought it might have to go to the insurance commissioner or something, but it apparently went to a judge. So that was what was fascinating. So I get this call, and I'm off from having had hip surgery recently. And I'm like, great, I'll get on the phone, call the judge, get all prepped for it, get on the call. And the insurance company comes and says, well, now we've decided to approve your procedure, because they didn't want to get their butt kicked by me with the judge telling them why they were so wrong. And I said, oh yeah, we approved it a week ago, but we're getting the paperwork ready to send it to you. It's like, yeah, I don't believe that. It's like a cat and mouse game. They wanted to see who would blink first, if we would quit and desist, because we're tired of it. And I think that's their game. I think that's their whole game, is pushing long enough till the physician gets tired of messing with it.
And I think a lot of both physicians and patients get tired of it. And they're like, you know what, just forget it. I'm just going to sit here and suffer. Like, I can't be bothered. I don't even have enough, fight in to even go each day, let alone having to fight insurance companies and fight in court. I mean, that's really tough. So coming up right here on the Heart of Innovation, I'm curious what conversations transpired between Dr. Barry Tedder and his patients and, the suffering that was involved over the summer while this patient was awaiting approval. So stay with us.
3 years ago, my symptoms started with
Explain
leg
on that
pain
side.
and leg cramps while walking.
Me too, with a tightness in my calves. But my doctor thought that my leg.
Yeah, this will be, now we're in commercial break again. And so I'd like to, because it's really with this disease, what doctors don't seem to understand and what, like even with the New York Times article, what that reporter doesn't understand and what even the ProPublica reporters don't understand is the repercussions that great, you did a story, you did a gotcha, maybe on one doctor or two doctors or three doctors. And in the case of the New York Times article, there was a lot of flawed information in there and it was wrongly directed. But it had this widespread impact that is just unconscionable. These patients, they don't understand that we're talking about the ones that they're writing about. There's just a handful. What we're dealing with is a mass of patients that literally are suffering in a grand way because of this. I mean, already we were having trouble with getting insurance to cover CLI patients where tinous tissue, these limb salvage procedures. And now it's even worse. And we might even want to, maybe Douglas will want to bring him in.
Yeah, I mean, I think we have to explore the fact that a lot of the patients that have P.A.D. and CLI are kind of marginalized at baseline. I mean, Barry, maybe I'm wrong, but like when I see my follow-up PCI patients, my coronary patients, they're different than the people that have P.A.D. I mean, like the socioeconomics are different. The insight into their disease process is different. And, I think it's easy for them, these type of patients to be, pushed around isn't the right term, but it's like marginalized and kind of forgotten.
They are. They don't show up for clinic as much either. I mean, that's
right. I mean, like
left out somewhere.
If everyone 1 minute till we air.
I mean, if I have a coronary clinic, it is so easy because these patients are just a lot more compliant, and the P.A.D. patients are just tough to deal with.
Okay.
And I think that leads to some of what we're talking about.
Yeah, do you want to lead us back in and we'll get into that side?
Yeah, let's hear, Barry, can we continue the story with your patient?
Yeah, we started back?
No, not yet.
We have about 20 seconds till we start back.
Yeah, sure. I don't have much more on her yet because we haven't done the last procedure yet, but.
Yeah, but I'm curious. I mean, she's suffering. I mean, people don't understand. Even to wait a day, these patients are seriously
10 seconds
in pain.
You can't go wrong. Choose wisely. Choose Wendy's new 2 for $3 Biggie bundles.
Limited time only. U.S. price of participation may vary. Not valid in a combo. Single item at regular price. 860 AM. The answer.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. Thanks for joining us. We're continuing our conversation with Dr. Barry Tedder. Barry, before we went to break, I was scratching my head a little bit about the whole notion of not having a peer-to-peer conversation about getting this procedure approved, because that's usually what happens in my state, or at least in the insurance companies we deal with, that, hey, maybe there's a question about why I want to do something. I call a peer, which could be a pediatrician, it could be a cardiologist, whatever. We have a conversation, I share more information, and typically, they move things forward for us. But in this sense, or in this situation, you're potentially going to be in front of a judge, and obviously now the insurance company says, no, we're going to approve the procedure. So we're waiting the procedure on this patient as we speak.
Yeah, the patient's been waiting, but that's typical of these claudicants, because sometimes she's been having these symptoms for years and nobody knew what was wrong with her. It's like, oh, it's your neuropathy, or your legs are weak. I don't know about you, but I've had patients come in a wheelchair before thinking they were something wrong with their legs, neuropathy. And, we work on them and they end up walking, and it was all because of weakness in their legs from an atypical claudication. So yeah, she's been suffering, but has been suffering for years, and she may have some neuropathy too, but it's, she has difficult diffuse disease, and we're just trying to get her in the system, and it takes a long, long time.
Yeah, the longer you wait to open up these arteries, the greater the chance that these patients are going to have permanent pain. Is that not the case? I mean, the damage to the nerves is not reversible.
These folks that are, the folks that are the claudicants, I think we have to differentiate between the claudicants and those with critical limb. So the claudicants, and I get the insurance companies, they want you to have exhausted every conservative but aggressive treatment option for the patient, which Barry, you did. She failed the medications. I always find it, yes, okay, fine, we're doing a walking program, but the patient really can't walk because her legs are so bad. But I think I've never had a patient with critical limb ischemia be denied a procedure. I think it's more the claudicants. I don't know about you, Barry.
Yeah, it's more the delay for the CLI than the denial. It's like they get approved, but it's the delay. I've gone to lately just saying, I'm just going to admit to the hospital. That's just the only way I can deal with, instead of somebody that has progressive gangrene that I'm worried is going to get worse. Maybe I'd like to do it in 5 or 7 days, but I don't think I can wait 2 to 3 weeks. So sometimes I've gone to just admitting them, and that's about the only way to get around the insurance issue, because then they'll cover it. So
yeah, I agree. I do. Yep. We end up doing that too, just because you don't have time, particularly if you're seeing people from out of state. I just have them come to our emergency room, which is not the best thing to do, but it's the only thing I know.
Isn't it more expensive for these insurance companies to have someone go through in the emergency room and end up with the procedure versus simply going through clinic and having the procedure?
I don't know for a fact, but I know it takes up a bed. Our emergency room is packed as it is. We've got kind of remote emergency rooms or parts of our hospital that serve as like an overflow. And so, the beds are limited. The patient's taking up a bed. They might be sitting, let's say they come in on a Friday. Well, we're not doing that case till Monday. So now they're sitting over the weekend. That's costing money. Yeah. So I would imagine it's more costly.
Gotta be.
And it's interesting. We had a patient last year who found the way to my heart, our 501c3 patient advocacy organization, while she was sitting in the emergency room waiting to be admitted, because she came to the emergency room with debilitating, she could describe it just as excruciating pain, as if a tourniquet was wrapped around her leg, and her tissues and her muscle, everything was just screaming. And the vascular surgeon came in, and it was a Sunday night. And he said, hey, we're going to amputate tomorrow. There's nothing that's going to work to relieve the pain. There was no, attempt to open up her blood vessels below the knee. And she found us as she was waiting to be admitted. And we talked to her and we said, well, if they're waiting till tomorrow to amputate anyway, we can get you into another doctor for a second opinion. And if they say amputation, you can always go right back to the emergency room and get that amputation. So she checks herself out, goes to this other doctor the next day. The doctor says, hey, I can open up your arteries today. And the insurance said, nope, you can't do this today. We need a few days to determine whether or not we're going to approve or reject this. And yet that same insurance company, because the patient went through the emergency room originally, they were going to pay for the amputation. That just doesn't make sense to me. I don't know if you've experienced that, but that I have. And I've also had other instances where insurance companies have a medical advisor, right, that reviews the case, where we've had pediatrician second guessing our vascular specialists who are on the front lines with these patients saying, hey, we got a patient with a gangrenous toe here. We need to do this procedure. And the medical reviewer, who's a pediatrician, is denying the case, saying, you need to have this patient on a walking program. And the doctor's like, the patient cannot walk. They have a gangrenous toe. What are you thinking?
Well, I mean, that's just an example of somebody following a script. I mean, I would imagine that they have papers in front of them in an algorithmic type of format that says, check this box, check this. Well, this box wasn't checked. Okay, well, you got to check that box before we do it. I mean, that's frankly ludicrous. I'm
How
speechless.
else could a pediatrician do it?
Yeah, I mean, but getting back to the original issue of the patient leaving and then going someplace else, and the notion that it's 2023 and we are still in the United States of America and patients are still being told that their first touch with any vascular event, like a vascular specialist, is an amputation is ludicrous. I mean, the notion of not considering angiography or surgery or something to help these patients just boggles my mind.
Yeah,
And that's why go ahead.
It's a lack of vascular specialists in our country. I mean, and it's the lack of our primary care physicians, ER doctors, internal medicine people really understanding vascular disease and its association with diabetic foot ulcers. I mean, I have a problem we've had to work at saying we need to see every diabetic foot ulcer. It's not just the diabetes, it's the blood flow, and they don't seem to get that for a long time.
No, I still have patients that come to me saying that they've had amputation because of their diabetes. They've never been diagnosed with peripheral artery disease. They're like, oh, you have poor circulation due to your diabetes. We're cutting off your leg. There's nothing we can do. And coming up right here on the Heart of Innovation, we are going to continue this conversation. So stay with us.
Do you ever wonder why people
Everybody's
with
clear.
peripheral arterial disease? I can't listen to that.
Why not? You're doing what you're supposed to do. You're eating the mic. You're making everybody feel comfy. You're making.
No,
them
I
learn.
told you. I don't know if
Stop
you guys
talking.
can
You're
hear me,
doing
but I was at the Bureau of Motor Vehicles trying to get my title changed over on a car, and I had to get this in for Kym, right, Kym? Because it was Friday. We had to get it in. But yeah.
Right. We're gonna make Dr. Tedder do a few of those.
So wait, what did you say? Like if I put my shirt over the microphone or like this?
Yeah,
Okay.
I take a jacket. Yeah, I take a jacket, and it's really fun. So you take your jacket and you put it over, and I mean, you can read. I mean, if you do a voice memo on your phone, I mean, you can read off your phone while you're doing the voice memo, right?
Mhm,
And
yeah.
the phone lights up. So you're in the dark, but the phone lights up. I mean, you can see what it says. I have actually pictures of me in like restaurants and stuff with my hood completely over me, the sweatshirt just hanging over me.
I imagine what are people like, what is wrong with her?
I don't think people are thinking what's wrong with her. I think, oh yeah, nap time sounds about right. By the way, everyone, just want to let you know we have about 3 minutes till we air.
Okay. And we need to, if we can, I want to get a few topics because that's why we're running yours again. I need a few more topics, and even ones maybe I can just do that would be okay.
Have we ever done one on like how to walk?
Yep.
We've done that. Okay.
We've done how to walk. We've done about 3 or 4 on how to walk, how to build collaterals.
I'll make a suggestion.
Yeah.
Bypasses is a big thing.
Yeah, we have two videos now on that. We have Dr. Oneida Duwa, who did 2 different videos on it. One, how to determine if a bypass is right for you. And number 2 is the different types of bypasses.
Then a show where the patients can talk in because it's still
an actual show. We have a show on the 21st. I think it's going to be on the 21st with Dr. James Joy. and we're talking about the minimally invasive bypass.
Oh, yeah.
And I think, John, next week we have Inari's going to be on. The
Oh,
Chief
yeah.
Medical Officer, Dr. too. And
That
I
was
hear
a-
that you've done a couple of those procedures. So, and thankfully they were successful when I asked them how you performed.
Oh, I'm glad. My shop is considered an Inari shop. So yeah, we do quite a few of those. That's a great device, honestly. Great device. I don't know. I know Tom not as well as some of my partners do, but yeah, it'll be an interesting conversation.
Yep. I figured that, I'll give you a heads up so you can get a few of your experiences together on that.
I did plenty of the PQ bypasses in that trial.
Wait, what? You did?
Oh, yeah. Yeah, I did a lot of them.
Ooh, maybe you could
I'm
join.
not, I'm not
showing
sold
it to
on
me
that.
first.
That's very
I could talk
niche.
off camera. I could talk off camera about it, but yeah.
Yeah, I'm not.
I'm not sold, but I think they need to make it better. Once they make it better, it's got good long-term results.
Well,
Short-
it's got what, a 5% DVT rate, I think, in the trial. Or
Just a heads up, 1 minute till we
a little less than that. That's
pretty
not the
high-
problem.
it's higher than I thought, but I think you have the right
The problem is
size.
the entry stenosis.
Another good show would be the mental
Yeah.
health aspect about PAD
Kim,
and
should we-
PAD.
Do we have anybody on the call that wants to ask a question? I mean, you guys, Douglas, your team here, you guys are patients, and you can, I think, express how you feel about what we're talking about, being marginalized. And
I do, yes.
Yeah. And that could be, but I don't know. We have Marlene who's here, and we have Anne, and we have Marcia.
Hate to interrupt, but we got 10 seconds, folks.
Throughout parts of New York City following torrential rainfall. This is SRN News.
8:60 a.m. The Answer.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and just Dr. John Phillips.
welcome back, everybody. We are continuing our conversation with Dr. Tedder, and Kim and I were just kind of spitballing about insurance companies and the headaches they provide. But I think it's a good time to bring in some of our callers. Douglas, I know you've been listening. You've made some comments in the chat, and I'm curious to see what your thoughts are, hear what your thoughts are regarding what we've talked about and potentially patients being marginalized and or kind of pushed aside regarding need for certain procedures.
As you were talking there, Mr. Phillips, I was thinking, so I go to the doctor, I do my thing with you, and then you send me home, and I have to wait for that phone call. And it's that in between that is what goes through my head about all the things, the insanity about, am I going to lose my leg? Is this going to happen? How long am I going to recover? And all that stuff. And that's the part where I don't feel included in that thinking process. And why wouldn't the insurance call me and say, Mr. Salisbury, how do you feel about this? And I'm letting some guy in some office somewhere make a decision about my leg.
I mean,
I know that has to be so frustrating.
So I've been waiting a week for a phone call from the heart doctor, and I'm still waiting. I fell again last night, but and it's like, so here I am still waiting. And every time I have a little moment with my heart, there's a thought process. Well, I'm just going to fall over now. It's like, that's it. So it's that in between. And we hear that a lot in the group about that waiting period, and we're not included in that thinking process, or we don't get those phone calls to keep us up to date so that our brains don't go places it's not supposed to be, like Google and YouTube and all that stuff.
I know Dr. Google is very, very popular when you're sitting at home suffering and waiting for insurance to approve a procedure, or even just simply to see a doctor.
And I'll be honest with you, I don't spend a lot of time thinking about there are certain cases that you see a patient and you're like, okay, I need to get that person in like tomorrow, or we're going to send them to the emergency room. But somebody that has claudication and that, I say, okay, let's set them up. And I don't think much about it, frankly. I just kind of, okay, here they are. That day they show up and we do the procedure. But that is something I maybe should think more about, I guess. I don't pay a lot of attention to it at the present.
But it's really good that you're not facing, the struggles, that people are not denying your claims. And it could be something with Ohio Health. It could be something with, maybe there's a state law that prohibits the denial, of a doctor. It's something that's worth looking into. We do have Dr. Jesse Martin actually calling in. Dr. Martin, hello. Thank you for joining the Heart of Innovation.
Hey, Kym. I have a question. Actually, I'm an interventional radiology resident at St. Louis University Hospital. I just have a quick question for the attending docs on, I think one of the biggest critics of atherectomy, most of them state the lack of randomized control trials. Other than, for instance, stenosis, there really hasn't been any randomized control trials for atherectomy. I personally believe in atherectomy. I've seen cases done with atherectomy that couldn't have been done really without it, done successfully. But the biggest critics usually point to that. What do you think the biggest reason for not having one, or not somebody else not doing one, is? And I'm curious if you think it should be done to shut some people up. Also, one thing about that, the biggest, just for people that don't know, the New York Times article was mainly spurred by a vascular surgeon at Johns Hopkins University. Johns Hopkins University is a major medical establishment. Usually doctors go there to do large trials and be a part of research. I think the better option for her would have been to try doing a randomized controlled trial proving that it works or doesn't work. Instead, she went to the New York Times and they wrote an article that frankly was exaggerated in a lot of ways, and not really backed up by comments with evidence. Maybe you could just talk on that.
Yeah, I mean, I'll share my thoughts and then I'll let Barry share his. So atherectomy, I doubt there's ever going to be a randomized controlled trial, because atherectomy is here. It's here to stay. And those of us that use it and use it appropriately know where it has benefit. The problem with atherectomy, in my opinion, in the OBLs, is that it gets reimbursed so much higher, and it's very lucrative to do. And there are certain types of atherectomy that are very, very easy to do that probably aren't doing anything. And so once you kind of we have to weed those people out. But for a company like CSI or Boston Scientific to do a randomized controlled trial of atherectomy versus, a cutting balloon or something, I just don't foresee that happening. We all know that there's not a ton of great data for atherectomy. But I mean, if you look at data for these drug-eluting stents and balloons, yeah, it's there. But there's a lot of people that don't even use that. And so, again, it all, in my opinion, a lot of this boils down to what's appropriate for the patient, and what tools do you have in your toolbox to use at your facility. And that's kind of how I approach this.
And my thing is if they do have an issue, if the insurance companies have questions as to whether or not a doctor is doing the right thing, the insurance company has the ability to say, hey, you know what? We're cutting you off, doctor. We don't want to work with you. I don't know that Medicare can necessarily do that, but I think that they are, in a sense, going after those physicians that they deem are taking advantage of the system and abusing the reimbursement. So I think the system is working.
Yeah, I'm going to step in on, I use a good bit of atherectomy too. And I think it's a very useful tool. And I agree. I think the peripheral space, not like the cardiovascular space, there's just not going to be that many great trials. We don't have all the data that we'd like to have to say X is better than Y. I agree with that. And the studies are not going to be done. But we know from experience, we see the value. I think one of the reasons, I think one of your questions was, why doesn't everybody do it? Why do they just use plain old balloon? I think part of it is just pure laziness. It's easier to get by with just sticking a balloon and a stent in than to try and debulk a lesion. So, and it's time, you're going to spend a lot more time in your cath lab doing it. So it's a lot more work. So there's those issues. But I'm a big user of the Pantheris OCT guided atherectomy, and I like to see the plaque and cut the plaque out, make a better lumen, and the balloon results are always better. And sometimes I don't have to lay a stent in the femoral artery. So I think that, it's somewhat the experience you get with one and how you see your results and your long-term results, which is what it's all about. The problem with peripheral vascular disease, it's diffuse and it tends to come back. And we honestly don't have the treatment that we have in the coronary space that works as well. So, and that's one of the reasons the New York Times article was there, is because people have so much recurrent disease and the restenosis rate is high, particularly with the smokers and the diffuse diabetics and the elderly, that we don't have as good a treatment as we like. So sometimes we have to do multiple procedures on these people. And that's just the state of the disease where we are now in the science of it.
And I tell my patients, when you get one procedure from me, you're probably going to need another one, because that's just the way it is. This is a progressive disease. It's got a high mortality rate than a lot of cancers.
Yeah.
And that's why we say, it's so much better if you can walk, and you can take some medication and you can get some relief and you can build those collateral vessels, it's always the best thing. And even with the ultimate Hail Mary of all Hail Marys, the deep vein arterialization, this newer DVA procedure where you hijack a vein to help reroute blood flow into the foot for those patients that are literally on deck for amputation. The idea is not for that particular procedure to be durable. It's to directly get blood flow to that wound, heal the wound, get the patient on their feet to walk, to be able to grow those collateral vessels. No need for zero to hero. We just need enough flow to get the patient on their feet to be able to become a partner in their care and walk to improve their prognosis. Coming up right here on the Heart of Innovation, we'll have more with Dr. Barry Tedder and, of course, my co-host, Dr. John Phillips. So stay with us.
This decade is looking like the worst one to retire or be retired.
Hope that was okay.
For more than 30 years.
Awesome. I like the
Charles's
zero to
retirement
hero.
Watch has been helping Americans invest.
Well, that's
Can
my
I
whole
say
thing.
something, Dr. Phillips?
Yes, sir.
I'd rather see you once every 6 months and keep my leg attached to my body. That is, or once a year if I do clot. I'd rather see you like that and have those little procedures done and keep my leg attached.
Yeah, that's why they went after Mustafa so bad, because they had such a high volume. And the New York Times article.
But I like my legs. I
get it. Yeah, no, it's there is listen, there are a few bad apples, but the vast majority of us are doing what's right for the patient.
Sorry to interrupt. We got 10 seconds till we hear everyone.
We want to get to Dr. Phillips. Do you want to take us back? And we want to get to Marcia's question. Marcia is a caller. She's calling it.
TheAnswer.com. This is 860 AM. The Answer.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. We are, as they say, rounding third with this show. Baseball playoffs are coming up, and we've got a caller. Marcia, you have a question for us. Welcome.
Well, it's not so much a question as a comment. What you just said about, like, you see a patient and you don't really, then you see them in the cath lab. Like, you don't give a lot of thought in between. I guess you have a lot of patience, and that's understandable, but I'll tell you what, I think the patient definitely feels that, because all I was going to say is my cardiologist, interventional cardiologist, is fantastic. And I think he knows me. I think he remembers me, knows everything about me. Now I'm seeing a vascular surgeon, and I don't even feel like I'm on his radar or his office. And it's a really helpless feeling as the patient to feel that you're not remembered, that you're not on their radar, they're not going to bat for you. And so
Yeah, well-
I don't know what the answer is, because I know you're busy and you have a lot of people.
I'll clarify that. I personally, we have an army of people that kind of track the patient for us. We're always thinking about the patients, but for me, it's like I say, okay, we're doing a procedure. My nurses, my MAs, they take care of it, and then I see the patient and we have the procedure. But I understand, yeah, you're kind of on an island there sometimes, particularly when you're not hearing back about what we're thinking. The nice thing about the EMR, it does allow us to communicate with our patients a little bit better for those people that are on Epic or whatever, where they're on their MyChart and they're texting, and the lines of communication are getting better.
And it's even more impersonal when it comes to these insurance companies. Dr. Barry Tedder, do you have final thoughts? We have about a minute left.
Yeah, I like those comments you just had, because I do think about that, but I'm just like Dr. Phillips. I'm seeing them as frequently. We do have nurses that are calling, but then they're overworked too. And we just don't have enough people to communicate with our patients. I've just got through seeing it on the patient side of it, because I just had my hip replaced 2 weeks ago. And I went through the ups and downs of being at home and worrying what was wrong with me. And, you don't even know who to call. I mean, you don't always have that connection. Even though I'm in the medical system, I felt isolated at home, that I didn't know, what to do because I was feeling bad. And so it's just, you have to be your own advocate. Unfortunately, the patient has to really make the calls and bug the medical system until they get their needs attended to.
Yep. It's just a matter of being, just on it and constantly being that squeaky wheel. Thank you so much, Dr. Barry Tedder. We really appreciate you. And for all of the callers, we appreciate you calling in and sharing your perspective and as well as your questions. Thank you so much, everyone, for joining us. I think this is a topic, John, that we're going to have a to be continued.
I agree. And I will just say that I'm going to think about that time period between when I was doing the procedure, when I want to have the procedure done and the procedure is done, and what's going through that patient's mind. Marcia, I'll be thinking about it, and we're always thinking about it. You got me.
It's always good to have that reminder, right? Marcia, we appreciate your honesty and your vulnerability and just being candid. It's awesome.
Thank you.
Thank you, everyone, for joining us. I hope you have a fantastic weekend, and we will see you soon.
The Heart of Innovation with Emmy award-winning journalist Kym McNicholas and interventional cardiologist Dr. John.
No hard feelings, Dr.
Our mission
Phillips.
is to help patients live a better quality of life through comprehensive education, real-time support, and high-touch advocacy in partnership with thewaytomyheart.org, and take a stand against amputation. Our purpose is to reduce the 1.5 million heart attacks and strokes and nearly 200,000 amputations